right, good afternoon, everyone. Thank you for joining us. This is the fourth, I believe, in our series for board education topics. This is the role of the hospital board with respect for quality. If you recall, we had a series of 3 previous webinars in late 2022. This is a topic that kind of came out of just doing site visits and visiting with folks, especially in the area of quality. And so we are very thankful to have Janelle with Arquita joining us today. We are a small live group. I understand many folks will be watching this via YouTube, the recorded session. So if you have any questions or if there's a topic you'd like explored, please reach out. Please let us know. I'll be watching the chat, but everyone on the call, you can unmute your own line. So if you have questions or if there's anything you want to share, please feel free to do so. With that said, Janelle, I will turn it over to you.
Well, thanks so much, Laura, and hi, everybody. Welcome to the session today. Just a little bit about me. I am a program manager at a company called Stratus Health, which is a quality and safety organization. I'm an RN. I've lived and worked in rural Minnesota for much of my career. Well, it's probably about half of my career now. And then working at a rural hospital, not quite critical access size, but a smaller rural hospital. I believe we were licensed for like 46 beds toward the end of the time I was there. But I worked on a lot of the areas, the med surge, ICU, OB. I was house supervisor for a while. And then the last years, I started their home care and hospice programs. Then my family relocated out of the rural area and moved toward metro Minneapolis, although we're in the suburbs. And actually now I live out in the country again. So I've been working at Stratus Health since then. And I work with organizations on quality improvement, looking at things across the continuum. So I get to work with hospitals, nursing homes, home health agencies, clinics, etc., and tend to focus on things that are community-based, things in the rural communities. Serious illness, end of life are kind of the initiative that I've been focusing on. So when Laura asked us to present on boards and quality, I was excited to do that. And I did a little bit of research, and some of these things I'll be sharing with you. But I would also love to hear about your experiences and thoughts. I'm hoping that this can be an interactive session. So our objectives today, just to understand how is quality measured in the hospital setting, to discuss why a board should be involved in quality, like why do you care? And then to identify some ways in which a board can improve quality at their local hospital. All righty, so Stratus Health, that's the organization I come from. I'll just tell you a little bit about us. We are an independent nonprofit organization. We're based in the Twin Cities, Metro Minnesota, but we also have staff nationally, and we do a lot of national-based work along with work here in our state. So we work at the intersection of equity research and policy and practice, meeting collaboration and innovation to drive healthcare quality and patient safety. So really, pretty much everything we do is with that quality and patient safety focus. And we work across the spectrum of care. As I said earlier, we work with all types of care providers in different settings. And we have a particularly long history of working with rural providers, both in Minnesota and nationally, including critical access hospitals and the Medicare Rural Hospital Flexibility Program and the 45 state flex programs in our state. And then today, I'm coming to you with the hat that we wear from Stratus Health for a project that we serve as the Rural Quality Improvement Technical Assistance Center, or ARQITA. And this is a cooperative agreement that we have with the Health Resources and Services Administration Federal Office of Rural Health Policy, or FORHP as it's known, and it's the entity that funds your state flex program. So in our role as ARQITA, we put on that quality and safety patient hat and focus on improving health outcomes. So specifically for those people that work and live in rural communities today. And so today we're going to be talking about the role of hospital boards in hospital safety and quality safety. Okay, so let's start out. So do we have any board members here today on our call?
No, I don't believe we have any on the live call today. Thank you.
Yeah, so let's just like if you were approached to be on a board, why do you think people say yes? So why do you think your board members say, yes, I want to be on your hospital board? What would be some reasons? Anybody have a guess? I'm assuming it would be something like they want to help the hospital be better or be as good as they can be. They maybe have, oh, here, public service. Thank you, Kat. The purpose of the hospital being in existence at all and defining who it serves. Boards want to make sure that the organization is financially sound and providing services to the community. So when we think about boards and quality, quality is a measure of an organization's success. And ensuring quality is job number one for boards, and they're ultimately responsible for it. So boards have a role in quality, whether they have a clinical background or not. Okay, so let's get into quality in healthcare a little bit now. First, let's get grounded by what we mean by quality. You might remember toward the turn of the century, the Institute of Medicine had two reports that came out that really changed the way we look at quality in healthcare. One was To Err as Human, and the other was the Crossing the Quality Chasm. And so what it did was really prompt healthcare leaders to address the patient safety crisis that we were having in our country, and to address systems, teamwork, and improvement sciences to help deliver safer care to patients. So the definition of quality was introduced by the report, Crossing the Quality Chasm, and it's actually still widely used today. So it is to the degree to which healthcare services for individuals and populations increase the likelihood of desired outcomes and are consistent with current professional knowledge. And the same report introduced the dimensions of healthcare quality. So while this is more than 20 years old, they're still being used as the framework for healthcare quality today. So you might remember the acronym for these, to help you remember, is STEEP, only there's an extra E, STEEEP, safe care, timely care, effective, efficient, equitable, and patient-centered. And then if you look at this diagram, it shows that there's a gap in healthcare quality when there's a gap between what we know from research and best practice and how we actually deliver care. For example, only 50% of hospital patients currently receive appropriate care for sepsis and septic shock. So when you look at the standards that are out there, and so that's a really wide gap between what we know and what we practice. So closing the gap is an essential role in quality improvement. And if you look at this diagram, you'll notice that at the bottom, there's a narrower gap. So that's where rapid, simple changes to our processes can be made fairly easily. So there's not such a huge gap. But then if you look at the top, there is a large gap. And that's where the knowledge, what's in the evidence, the research, and what actually happens in patient care, there's a big gap, and it takes the application of quality improvement science, culture, and tools. There's a much greater need for that. And in healthcare, we're continually learning new and better ways to improve health of the populations because of the constant research that's going on and the delivery of care to individuals. So there's always opportunities for improvement. And unfortunately, there's almost always a delay in time from knowledge to practice. And it takes a long time to get a new evidence-based practice into practice. So if you look at this diagram, it's another way of looking at quality from a patient perspective. As a board member or as a person in the community, you might resonate more with the view of quality that uses a patient lens. So I get this diagram from a framework from the Institute of Healthcare Improvement for improving board governance for healthcare quality. And so this looks at it from the patient lens, and the patient perspective on quality might be more motivating for your board members to look at. So it actually depicts the core components of quality, from the STEEP model, but it's a refined model. For example, the STEEP dimension of timely and efficient care are combined into help me navigate my care. Like we can understand that easier, right? And the STEEP dimension of equitable and safe patient-centered care is aggregated into treat me with respect component. So types of data that you may see. We're going to split it into two buckets at first, and then we'll talk about types of measures. So two main types of data would be quantitative and qualitative. Both qualitative and quantitative are helpful in quality improvement efforts. Quantitative data includes the use of numbers expressed in measurable units. So quantitative data is often continuous, such as height or length measurement. It is objective and produced through processes that are variable, replicable, and not subject to interpretation. So it is what it is. Quantitative data can be very helpful when you're looking for patterns and themes, such as calculating the percentage of patients that received an appropriate health screening or averages of lab values, tracking timeliness of patient access to care. Other examples might be just things like blood pressure, the hemoglobin A1C, or other similar lab values, height, weight, time, things like that. And then when we look at qualitative data, these are descriptive characteristics rather than numeric values. So qualitative data can also be categorized, placing observations in specific categories or conveying attributes and properties. So it's important information about patterns and relationships between systems, and often it provides concepts for needed improvements. So examples of qualitative data would be things you get from patient or staff satisfaction surveys. Maybe you do focus group discussions or independent observations. The race, ethnicity, language data that is collected regarding health-related social needs and social drivers of health or qualitative data sets. They're used to better understand your patient population and identify health inequity. So qualitative data can also come from things like meeting notes or discussions, narratives, such as an encounter note. And then types of measures that you'll hear about are outcome measures, process measures, and you might hear about balancing measures as well. So let's just talk about the difference between these. Outcome measures, they measure our outcomes. So what was the impact on a person or the community members? Did the change in process have a desired result? So an outcome. Measuring the processes itself is not enough if your outcome is to assess whether the change you've put into place had a desired effect. You want to see a change in outcome, such as eliminating maybe the recurrence of a harm event, for example. Other examples of outcome measures might be number of patients diagnosed with high blood pressure or hypertension that have their blood pressure under control. That would be an outcome. They have controlled blood pressure. Or patients diagnosed with prediabetes that have not progressed to diabetes diagnosis within 1 year of that prediabetes diagnosis. There are lots and lots of outcome measures. For access, it might be number of days to the next available appointment, or ICU might be looking at unadjusted mortality rates. And then we get into process measures. So these are assessing our processes, how we do things, the steps, the procedures. And things we look at is, are our processes working for us? Are we using them? Are we using them consistently? Are we using them accurately? And then you look at, is a process or procedure, if that's changed as part of a corrective action, it's important to know that the change actually occurred. So if you think, well, if we implement this new process because we want to achieve an outcome, you want to make sure that the process is working and that staff are actually using it in the way you intend them to use it. So process measures might be things like, like when a patient comes into the clinic and they have a high blood pressure, did you take a second screening of that? Or the number of patients over 18 that are screened for prediabetes. So it's a process that you do. And then the third type of measure are balancing measures. And this is to look to see if one of the changes that you've made in the system is causing an impact on another part of the system, especially if you look, for something negative. So for example, if you're trying to reduce length of stay in a hospital, you want to make sure that your readmission rates aren't increasing. Or if you want to reduce the time a person has spent on a ventilator after a surgery, you want to make sure that reintubation rates are not increasing. So let me just stop a second here and see if there's any questions about the data slides that we've just talked about, whether it's the types of data or the types of measures. So why should the board care about quality, or why do you care about quality and safety at your hospital? And go ahead and either unmute or just put it in chat. Why do you want your hospital to have high quality and good safety? Any thoughts on that? Yeah, for the patient, right? You want patients to have the best experience possible. Provide great patient care. And many times in rural communities, you're caring for your neighbors and people you know or know of, right? When you work in a larger hospital, a lot of times you don't care for people you actually know, but in a small hospital, I remember working, and when I was at the Fairmont Hospital, I had people ask me all the time, "Are you the daughter of so-and-so or daughter-in-law of so-and-so?" Some well-known person in the community. It happened I wasn't, but everybody knew this person with the same last name, and they wanted to know if there was a connection there. All right, thank you. Let's move on and talk about why boards should care. So in my research, so I looked at literature and I looked at some resources for helping boards be engaged in quality, and I kind of bucketed them into these reasons. And honestly, there's probably more as well. So I'll just kind of read through them and then we'll dig into each one a little bit. So to meet the needs of the community, right? You want to give safe care. You don't want people to be harmed when they come to the hospital, but to have safe care and heal. You may be familiar with that value-based payment is coming for rural hospitals. So that would be a good reason for boards to care about that. The payment will be changing. Research actually shows that there is better quality with board engagement. Boards have a great opportunity to leverage for quality and patient safety. And then boards have a fiduciary responsibility for not only for the financial well-being of a hospital, but also for the quality of the hospital. And then there are actually regulations that says a board should be involved in quality, and we'll look at those in a little bit. All right, so let's go into each of these areas. So community needs. So boards have the strongest connection to the community, right? They represent the voice of the community and the patients, and thus have a main role in strategic planning for the hospital. And this perspective is needed as a hospital designs their services to meet the needs of the population. So what are some community needs that your hospital has focused on? What are some things they've taken into account at your community? And it might be things like services, say like having local kidney dialysis so people don't have to drive so far for their dialysis, or maybe a program like cardiac rehab, or it could be health outcomes. Some communities notice through their assessment that they have high obesity levels, and that has consequences with cardiac illness and diabetes and different health conditions. So they may be working on that. So as a trustee of healthcare organizations with missions to improve the health of our communities, measuring and eliminating harm is also a responsibility of the board. When you think about what is patient harm events are things like pressure ulcers, surgical site infections, injuries from falls and immobility, adverse drug events, and many more. There's lots of harm that can happen at a hospital. Healthcare is so complicated and complex that areas of harm can happen to people. Patients expect safe and good care. They don't expect to go to the hospital and to be harmed, right? Okay, I go back one more to the triple aim. I was a little ahead of, had a lot of talking on that one blue slide. There we go. So you may have heard of the triple aim. This was developed by the Institute for Healthcare Improvement. It's been around a long time. So actually like in 2008, and it's an approach to optimizing the health system performance by pursuing balanced improvement across three areas. So improving health of populations, improving the experience, patient experience of care, and then reducing the per capita cost of healthcare. And the assertion of the triple aim is that when pursued simultaneously, the aims reinforce each other, and we can achieve an optimal balance of health outcomes, experience, and cost. So since that time when the triple aim was first formed, two other aims have been suggested. So in 2014, they added workforce well-being and safety, resulted in the quadruple aim, calling attention to the growing challenge of burnout. And, with this pandemic, we're really hearing a lot more about healthcare professional burnout, right? And then recently, the current Institute for Healthcare president, Cedar Mott, proposed expanding to a quintuple aim, calling out equity as its own point on a 5-star point for the triple aim. So some people refer it as a quintuple aim. And then when we look at the value equation, so next slide, please. Yeah. Is this equation provides a way to understand how well an organization is performing the vision of STEEP, those 6 areas, and the framework of the triple aim. So it's defined as the quality of care, which is made up of outcomes, patient safety and service, divided by the total cost of patient care over time. So that's value. And then I also want to point out that there really can't be quality and value without equity as well. So that's an important component. And I think we're focusing more and more on equity in our healthcare systems. And I'm just seeing the comment that you had in the chat, Kathy, about providing services near their home for patients following ortho surgeries. So they aren't having to travel so far distance, or maybe it's for PT or therapy afterwards. Okay, let's talk a little bit about value-based payment. So if you can find the emoji, I want you to put a thumbs up if you've heard about value-based payment, or your hospital's maybe talking about it or doing something with it. Yep. So value-based payment, let's just talk a little bit about this here, is with the rising cost of healthcare and the aging population in rural communities, combined with the thin margins that rural hospitals often operate under, making the traditional system of delivery and payment of being paid by volume, it's just unsustainable over the long term. So to address this, CMS has championed, so CMS is Centers for Medicare and Medicaid Services, has championed a value-based care approach. And the intent is not only to lower healthcare costs, but also to build healthier populations of people. So we're moving away from a payment for procedure to a new payment system based on value. And this is a system more focused on prevention and wellness. It's a holistic approach. A value-based approach rewards for quality and efficiency rather than just quantity, which is the way the current system for critical access hospitals is. So payments are based on the hospital's ability to demonstrate high quality measured by objective experiences of care and patient experiences as measured by subjective experiences of care at lower cost. And so we need to meet patient healthcare needs early before they even need hospital level care. Population health is closely related and connected to the value-based approach, as better outcomes for a population would provide more payments to the hospital. So looking at the population that you serve. So the role of the board here is to provide guidance and strategic directions to promote a culture that embraces this change. So this diagram explains it a little bit further. Value-based payment models are programs that pay providers based on outcomes and quality of the care they deliver, not volumes, not the amount of tests or not the amount of hospitalizations, but on outcomes, patient outcomes. And so they are designed to lower costs, increase quality, and promote equity in healthcare. They use measures of quality and cost to determine payment for providers, which may be developed and imposed by different entities. And there are different types of value-based payment models that you may have heard of, such as pay-for-performance, bundled payments, shared savings, and risk payments. There might be capitation. And these models vary in the level of provider accountability and financial incentives that they entail for the providers. So are any of your hospitals now involved with any of these value-based payment models? Maybe with a certain type of payer, or are you in an ACO, accountable care organization? Where are your hospitals at related to value-based payment? Is anybody doing anything? Even a thumbs down. So I'm just curious where you're at with this. All right, doesn't look like anybody is sharing that there's some work, but maybe there is. And so let's just move on to the next slide and talk about what we're noticing with rural communities in the value-based payment. So those of you on the call are part of, I'm assuming you're a part of the MBQIP, the Medicare Quality Improvement Project. And this was launched around the time of the Affordable Care Act. And the part of it is to establish payment for quality for non-critical access hospitals with the Affordable Care Act. And when CMS or Centers for Medicaid puts into place a paying for value, it's usually rolled out gradually. So it starts out by voluntarily reporting. So reporting your data measures. Then it moves to pay for reporting. So they pay hospitals to report. And then it moves to pay for performance. So they're paid for how the hospital actually performs with their quality metrics. The MBQIP program is the voluntary reporting. It's the on-ramp for pay for performance. But when we look at where it's been rolled out so far, it's been in non-critical access hospitals, so PPS hospitals, the end-stage renal disease networks, home health has a new pay for performance model, long-term care, physician payment. So the other areas in healthcare are already experiencing value-based payment programs. So we are seeing increasing engagement by rural providers in alternative models. Many are part of a rural ACO or a health system ACO. And there's broad movement across payers to be a part of this. And we're seeing as we go through government administrations, the theme continues to have this value-based payment. This table shows just kind of the movement. So CMS has convened the Healthcare Payment Learning and Action Network. And they are saying by 2030 that all traditional Medicare and Medicare Advantage will be tied to quality. So the payment will be tied to quality. And the goal is regarding payments to the healthcare delivery providers. So that Medicaid, right now, Medicaid and commercial payers, they don't really differentiate whether you're a critical access hospital or a PPS hospital, prospective payment hospital. But it will be coming more and more that Medicare Advantage and traditional Medicare. So the goal is 2030, which really is not that long away right now. So it will be coming. We don't exactly know when it'll be coming for critical access hospitals, but where Medicare leads, they're planning on it moving into all aspects of the care. Okay, thanks, James. I see here, not currently, but doing an ACO. Okay, so some of that kind of methodology with value is a part of the ACO model as well. All right, so now let's, the next one is there's better quality with board engagement. So following those two Institute of Medicine reports I mentioned earlier, research on healthcare governance practices identified a correlation between health system board prioritization of quality oversight and higher performance on key quality indicators. Quality oversight by a board has been shown to correlate with patient outcomes on these key quality metrics, and boards that prioritize quality and support a leadership commitment to quality in the incentives and oversight to achieve quality care that patients deserve. So the more boards are engaged in quality, they've been able to associate with better quality data at a hospital. In some of the articles that I referenced, they also indicated the same thing. There was one written by Miller et al., and they looked at 122 studies for detailed review. And the results of their findings were they linked board composition and processes with patient outcomes and found clear differences between high performing and low performing hospitals, highlighting the importance of strong and committed leadership that prioritizes quality and safety and sets clear and measurable goals for improvement. So effective oversight is also associated with well-informed and skilled boards. Boards need to lead. Boards need to understand not just the mission of the organization, but how they can help accomplish that mission. They need to be able to set big picture goals, how to set targets for healthcare goals. Boards can also leverage for patient safety and quality. And boards are important in leveraging when we think about the three parts to making change. You need to see the problem, own the problem, and fix the problem. And boards need to be able to see the problem and own the problem and understand, because they are the ultimate authority of the organization, and they're in charge of overseeing the medical staff and the credentialing process. Also, the CEO performance evaluation process, boards are responsible for that, and that they control the levers of systems. And then, and only then, can they begin to fix the problem. So we'll talk about some things that the board can do to leverage improvement in quality. So I thought, it's kind of great to know that there is data that supports board engagement and quality. So next, let's just talk about a little bit about board requirements and regulations. So boards are responsible for overseeing as a fiduciary quality improvement performance, as well as financial performance. In the boardroom, quality is often lower priority than financial oversight. In a study a few years ago in 2017, they found that quality performance was on the agenda at every board meeting in 63% of US hospitals, but financial performance was always on the agenda in 93% of hospitals. So we want to get that quality to have a higher performance. So the slide that you see here shows the conditions of participation. So I just went out and found the conditions of participation for a critical access hospital. So these are the regulations. And you can see here that the board is accountable for quality program at hospitals. I put the link in there if you're interested. So board oversight in quality is not intended to micromanage the work of senior leaders, but to engage in a thoughtful inquiry and ensure that organizational performance aligns with the expectations established by both leaders and board members, trustees. So boards can support health system leaders in their efforts to improve quality in many ways, including things like conducting rounds, visiting the point of care, thanking frontline staff for their contributions to improving quality and safety, being engaged when data is presented to you. And boards can also support quality work by including time on the agenda to hear things like patient stories, which personalizes the data. So those were the kind of the why. So now, what can board members do to actually improve quality? I'm going to talk about that next. So some things you can do. So as I was looking in the literature, I came out with 8 things. I'm sure there's probably more, but I wanted to just highlight these. One is get educated. So get educated when someone is presenting data. So you understand reports, you understand the terminology, you understand statistics. You know what safety culture is and you promote it. You know what just culture is, teamwork, how that all works. There's opportunities for internal and external education for board members. So education would be more like the education that maybe the quality director or folks at the hospital are providing board members. Like onboarding new members. Usually there's an orientation time. You might meet with the director of quality and safety where they explain some of the terms and the reports and the data that they'll be hearing at board meetings. External educational opportunities refers to programs and content that might be delivered by a state association or a national association. Conferences, publications, webinars such as this one. And so they're not organization specific, but they would be available to board members across. I know our hospital association here in Minnesota puts on conferences specifically for hospital boards and other trainings. Second, be a quality and safety committee member. Every board should have a quality oversight committee made of board members, patient safety experts, quality experts, and other community members to help guide the organization and set organizational quality goals and priorities. Some hospitals actually they assign new board members to serve on the quality committee for their first year on the board, just to help them on board and learn about quality and get a knowledge base, but that it's so important that they understand and be a part of that. When selecting board members, do you look to see if they have knowledge about quality and safety? I mean, it doesn't have to be in healthcare. It could be things related to systems improvement in business or manufacturing. Some folks have expertise in lean that can also be applied into healthcare. So there's many areas that can be generalizable to healthcare. You want a well-rounded board that brings many competencies. Many community board members have financial and leadership competencies. You might also have a physician or a nurse on the board, and they can be a great resource to bridge that clinical, maybe that gap that hospital management and board leadership might not have, to help provide some of the details for patient level care. Another thing boards can do is engage frontline staff. So you'll hear, hopefully, hospital reports from hospital or from leaders. So maybe a department director comes or somebody from the staff comes and presents at board meetings. So this might be nurses, physicians, quality folks, other hospital staff may present. Some boards do rounds on the floor. And so get out of the boardroom and get into the clinical room units. It's a beneficial experience, both for the board member and the caregivers at the bedside. It allows board members to see what it's really like for the day-to-day activities that, what are they really like for the clinical staff? What are they dealing with as they take care of patients? It allows staff to see those that are at the highest level of the organization, that they really care about this. They're setting priorities, they're setting strategies, and they really care about patient safety and the culture of safety. Boards should have open and candid discussions with clinical staff about performance in different areas. And because boards may not have clinical background, it's important to set goals together with clinical leaders in the organization and to identify champions that can help boards as they enhance their clinical support and engagement learning. Another thing is to engage in patients. How many of you have patients come to board or committee meetings to share their stories? Give a thumbs up if you have that at your hospital, where boards actually have a chance to hear from real patients about their experience. It could be good or bad. Anybody do that at your hospital? The patient voice is really important to be heard in the boardroom, and it includes positive stories and the stories that you probably don't want to hear, the negative stories. But it's good to hear those things and the challenges and what patients bring a different perspective on what it's like to get services and care at your hospital. And it's important for you to ask good questions like, how could we do things better? And not be defensive when you hear maybe the negative stories. Many patients and families are interested in helping their local hospitals be as good as they can. And if they can give some direct feedback to help you improve, they want to do that. They want to know that at the hospital, like what you would do, what you could do to prevent if there was a bad situation or a harm event, what you could do to prevent that from happening to other people again. And a good suggestion also is to include patients on safety committees and including the quality committee. Okay, thanks, James. So getting letters from patients. So it sounds like your hospital maybe shares the letters at board meetings or some of those comments. Very few have. I've heard from hospitals that have started bringing patients in that it's a really powerful experience and it's a way of really connecting with the people in your community. It makes you vulnerable. I mean, that's for sure. But it's a great practice. So I would really highly recommend considering doing that. Many boards start their board meeting with a patient story. I've heard that as I've been working with hospitals as well. Okay, let's talk about how you can support a safety culture. So board members can support and promote a safety culture. It's the board's role to ensure the desired culture is achieved and includes things like respect, transparency, and accountability. Safety culture involves training, education, resources, trust, respect, and a clear set of expected values and behaviors. And it is the board's role to ensure that the desired culture is achieved. Ensure a culture of safety, of respect to make safety better. So when there is a strong personal trust, strong respect among teams, things get done better and are done more safely. So things that board members can do is recognize staff for quality. So if somebody is doing some great work on quality, give them some kudos or recognition for that. Ask staff if they have the resources that they need to do the job. Do they have the training that they need, the education and other resources? And ensure that the organization has an overall culture that highlights the need for continuous improvement and that rewards continuous improvement and celebrates, that's really important that you do celebrate improvement that happens over time. Board members can respond to harm events. So not only to hear about it, but to help identify the problem and the solution. That's why it's a great idea to have board members a part of your quality teams. They can ensure that the hospital has a patient harm composite metric that's being tracked. So are you looking at a metric on a monthly or maybe quarterly basis that you can identify improvement opportunities? And it's more than just measuring, it's more than just tracking, but at the board level, looking at what the strategies are to eliminate the patient harm and really helping getting to the root cause. What are our patient and family engagement strategies to involve patient and families in these processes? Are you bringing them in? What are the leadership incentives in alignment to eliminating patient harm? Many senior leaders get bonuses and incentives when the data is good. And what are the data and information needs to help eliminate patient harms? And how do we get that information to the front line? Do you hear from your hospital leadership or QI committee how many people were harmed in the last month or quarter? Is that something that you're saying out loud to boards? It should be, because you want to be transparent about these things. What kind of questions can you ask hospital leaders and staff on ways to prevent harm to patients? And then ask the hard questions. As a board, you have a responsibility to make sure the quality is high. So it can be your role to ask the hard questions like, what are the systems of improvement? What are your processes that you're working on? Maybe somebody presented on a quality improvement initiative or talked about a harm event. Follow up on that. What happened? What did you change to make sure that that didn't happen again? And then hold leadership accountable. for improving quality in harm events. Ask for a follow-up for an event or situation. Find out what was done to prevent something from happening. And then oftentimes, like I said, payment incentives are tied to quality scores. So really holding leadership accountable for the quality at the hospital. Anything else you can add as far as what a board member could do to help improve quality, or how they could help you at your hospital improve your quality? Boards are also responsible for budget, right? So to improve quality sometimes takes money. And so they can help with the allocation of funds. And when they understand the needs of quality and the gaps and what is needed to improve it, they can help with allocation of those funds. So let's just open it up here. So as a board member, or if you have thoughts on a board member, what opportunities do you see that could be leveraged to improving quality and safety at your own hospital? How would you like to use your board members to help you improve your quality? Thanks, Melba. Relay community information back to the quality committee. Yes. So there's that communication. I mean, you're the representative of the community, right? Um, you know what's going on in the community. You probably hear things that are going on in the community about the hospital. You can bring that back as well. Any other thoughts? Do you see your board as a group that can impact your quality and can help you improve your quality? Yes, I certainly hope so. You know, I think it used to be more board meetings were like a closed, closed meeting, just the board. But now more and more hospitals are having staff present and getting to know board members more, bringing patients and families in, and just opening up more to that quality side rather than just the financial side and the operational side. Yeah, absolutely, Melva. Bring in that layperson perspective. You know, in healthcare, we talk in a language that's foreign to people that aren't in healthcare, right? Just the terminology we use, and to really bring that community person's perspective and understanding and ideas. Any other thoughts or comments on how a board could help? I feel that boards find even more meaning to being on the hospital board when they hear and learn and know that they're involved in making care better and the best it can be in that community. Because you want people to stay and receive services from you because the quality is high, right? Okay, I just have a couple more slides, and these are some resources for you. If you're looking for resources for boards, there is a video series that was developed a few years ago where there are a series of videos, and then there's a bunch of questions that you can ask of your board, and I've used some of those in the presentation. There is also a framework. This next one is from the Institute for Healthcare Improvement for effective board governance. And they also have assessments that boards can take of each other. Stratus Health has had a program with quality improvement mentors, national mentors, and there are a couple of podcasts on involving the board. And then here from our National Rural Health Resource Center, there's a good program for board members about transitioning to value-based care. And so there's a number of webinars, recorded webinars that you can use there. And then the last slide just shows some of the resources that I used in my presentation if you're interested in digging deeper into it. So that's all I have. And if anybody has any comments or questions, I'd love to hear from you. Anything else to add about why you want your boards to care about quality or what they can do to help you?
Hi, Janelle. I'm not seeing anything come through the chat, but we will be sending out the slides, and we did record this, and so please feel free to share this with others. If you have thoughts or ideas, or hey, I'd like to hear more on this topic, please let us know. If there's any questions, please let us know as well.
Right. Thank you, Laura. Thank you, everybody, for being on the call. I hope you enjoy working with your boards, and thank you for your time today.
Yes, thank you, everyone. Thank you, Janelle. Everyone have a great day.